Welcome to the VHA Innovation Ecosystem Podcast, a podcast from the Department of Veterans Affairs that focuses on all the innovative work being driven by frontline VA employees to improve veteran care. I'm Dr. Ryan Vega, Director of the Diffusion of Excellence Initiative, which is one of the efforts of the Department of Veterans Affairs that is focused on identifying, evaluating, and spreading innovative ways to effectively and efficiently meet veteran needs. Our first episode focused on approaches to combat suicide among at-risk individuals. If you haven't listened to that episode yet, give it a listen. It's available where you found this one. Our second episode focuses on innovative practice aimed at combating the opioid crisis in the United States. Until recently, opioids were the primary mean for treating pain in veterans. According to data from a 2013 analysis by the Center for Investigative Reporting, opioid prescriptions rose by over 270% over 12 years in VA hospitals, exacerbating opioid addiction and overdose. Furthermore, a 2011 study out of the University of Michigan found that veterans were twice as likely to die from accidental opioid overdoses compared to non-veterans. So how can we prevent and mitigate complications posed by opioid use while still effectively treating veterans suffering from chronic pain? Well, VA employees are actively working to address this complex public health issue amongst the veteran population. On today's episode, we'll feature two practices created by VA employees to help address the opioid crisis. In one practice, a team created a comprehensive pain management program that streamlines the process for referral management and educates and empowers veterans on alternatives to self-managed pain. Elsewhere, VA employees are addressing the high incidence of opioid overdose by enhancing the education and distribution of intranasal naloxone, an opioid reversal agent. Finally, at the end of this episode, we'll feature a nonprofit organization that has established effective addiction treatment and support to meet the needs of those living in pain. Before we dive in, if you or a loved one are a veteran or service member and are struggling with addiction, please dial the Veteran Crisis Line at 1-800-273-8255 and press 1 to speak to somebody that can help. Our first practice started at the Tomah VA Medical Center. Pain University is a comprehensive chronic pain management program for veterans that streamlines the process for referral management and creates a standardized chronic pain education program to educate veterans and empower them to self-manage their pain. Courses range from basic pain management to electives like yoga and aquatherapy. I'll now turn the podcast over to Blake Henderson, Deputy Director of the VA Diffusion of Excellence Initiative, who will speak with Dr. Kristen Enenberg-Bolden and Dr. Wes Krzyzewski. Dr. Enenberg-Bolden is the Physical Medicine and Rehabilitation Services Manager at the Tomah VA Medical Center. She is also the Pain University Lead and Gold Status Fellow. Dr. Krzyzewski is a physical therapist and Pain University core instructor.
Hi, this is Blake Henderson with the Diffusion of Excellence Initiative. I'm here with Chris and Wes, representing Pain University. Chris and Wes, would you all mind introducing yourselves?
Sure. My name is Chris Enenberg-Bolden, and I am a doctor of physical therapy. Went to Des Moines University for that, and also undergraduate and graduate studies at University of Illinois in Indianapolis. I'm from the Midwest. I'm currently the physical medicine and rehab manager here at the Tomah VA.
And this is Wes Krzyzewski. I also have a doctoral degree in physical therapy, mine from the University of Minnesota, where I graduated in 2005. So I've been in practice for a total of 12 years now, and the last 5.5 with the VA, which has been wonderful.
Would one of you mind describing the problem area that you're working within with Pain University and what Pain University represents as a solution?
We're working with any patients that have a persistent pain condition or patients who don't want to have an acute injury turn into something that is a persistent pain condition. It can be with patients who use opioids or patients who have never used opioids. So one of our goals is really to help supplement the opioid safety initiative to reduce opioids, but at the same time prevent opioids from ever starting. There's so many things we can do to prevent that. So, that is a major initiative, is to address the opioid crisis, but at the same time, a lot of it is to prevent it from ever happening. And so by working with a supportive group of professions, not just physical therapists, although Wes and I are physical therapists, it encompasses really all of those professions that treat pain. But we work together and we deliver it in a way that is familiar to a veteran. Pain treatment, there's so many options, and it can be so confusing and overwhelming to patients that we really made it simple for them to become the best educated people about their personal pain conditions.
If I'm a veteran, and I start doing Pain University, what kind of experience am I going to have? Can you walk through that a little bit?
There are a few different ways in which a veteran can start their Pain University experience. And once the consult is entered, whether it be from primary care or from our whole health coaches or any of our other multidisciplinary colleagues can enter a consult to Pain University, it begins with a couple what we consider to be the prerequisite classes, Pain 101 and Pain 102. Now, these classes are built around a concept known as Explain Pain or Pain Neuroscience education, which is a very specialized and specific style of education. Now, historically, in treating pain, we've always educated people, but this is a particular style of education that has been well researched over the last 10 to 15 years, and we're learning that when we have a chance to have the conversations that we have in Pain 101 and 102, that it really sets the stage for people with persistent pain to have better success in the long run on their pain treatment goals. So we have a whole slew of what we consider elective classes, and none of them are necessarily required after 102, but we strongly encourage them and try to facilitate some reflection on the veteran part regarding what path might be most important to them, because no two lower back pains are the same. I mean, there's some commonalities, but everybody has their own factors involved in their pains.
I was just going to add to that, too. One thing that we've recently introduced is the concept of coaching. And we traditionally have had our therapists and our nurse mental health providers that are also trained in pain science that can help coach that patient. So they do get some individualized. It's not just the two classes. And so our lectures are traditional lectures. But as you go to school, there's also labs. Even in high school, we have labs, and the labs are what we consider the treatment. So as Wes mentioned, that the exercise portions, the activity, we know that motion and movement is beneficial to people who have persistent pain, but also the mental health treatments as well. So incorporating that all together.
That's really neat how you give folks kind of control over their pathway. I imagine that gives people kind of a sense of ownership of their care and a sense of agency. So that's really cool. I actually have someone close to my family who experiences chronic pain, and they're a wonderful person, and you can just see how it kind of affects them, not just physically but mentally, and how it just kind of wears on your self-esteem, I think, over the long term, because some folks who don't understand the condition, maybe might think that they're just lazy or that they don't want to do anything.
Right. There's so many factors that go into it, and actually, we have a class called The Stigma of Pain. You're exactly right. And I would also want to add into that a lot of times, fear is a factor, and that they're afraid to move. They're afraid that if they do something, it's going to make things worse. So some of the things that we do and why we really promote a lot of active engagement and movement, and that is to let them realize that they can do more than they think they can do, and help them through that, coach them through that, not just say, hey, go out, your plan is to walk a mile every day. No, we're going to take it in little steps and see what you can do and slowly tease that out so that you can progressively improve over time.
How do you measure the success and impact of Pain University?
The standard things that you do with all clinics in VA, we look at our access and our satisfaction in terms of our participation levels. One of the other things we like to look at is that, did we lessen the burden on the staff? We've taken some burden off the primary care providers. It's certainly made it easier for the therapists and the psychologists that treat the patients to have this together. But really, when it comes down to the measuring of the numbers, our biggest thing is really looking at that quality of life.
We will ask the 0 to 10 because it does have value, but we also ask them to rate what we refer to as the flare-ups. How often they're happening, how long they're sticking around, and as Chris mentioned, how they're influencing quality of life for folks. And even if they still hit 8 out of 10 3 months later, but if it's not happening as often, or not lasting as long, or they're able to spend more time in their yard before they get there, while they can still hit 8 out of 10, there's other parts of those characteristics and quality of life pieces that are still improving for them, and that's definitely a meaningful thing.
Let's see. So how many veterans have enrolled in Pain University and completed it?
I can tell you we've had about 600 consults in the past year and a half, and visits are well over 4,000 at this point.
Wow.
All the different, so we've been doing a lot. It's been very popular, and in looking at our trends over time, it looks like a mountain range that just keeps getting taller. And so I got together with the mental health leader, the manager over there, and we decided to embed this into our residential substance abuse program. And so we've done that, and that's been successful as well.
So I have to ask, you guys have developed, it seems like this whole framework kind of from scratch based on your clinical knowledge and also creativity. I mean, how do you feel about this program? Like, are you proud of it?
Yes. From a personal perspective as a clinician, all of my years of training and experiences coming together to really build where I'm providing the most value. And I'm providing the value not necessarily as a clinician, but as getting the rest of the staff to really build upon what they want to see and how to really make their careers valuable. And I know just across the board, just complete pride from all of those involved, and also from the veterans and our veteran service organizations. They're some of our biggest proponents, that they're just proud to be able to say, yeah, I'm from the Toma VA, and we do Payne University there, and you should learn more about it. From the personal side, definitely, but it's even more rewarding to see all of the staff and the veterans that have been involved just kind of beam when they've met their goals, or when they talk about it to other people at our outreach events and things like that. It's definitely a sense of pride.
This has been a great conversation. On behalf of the Diffusion of Excellence program, we're just so proud to be, associated with you guys in your work, and we're committed to seeing it grow as well and be sustained.
Yeah, thank you for your continued support and the opportunity to be a part of this interview. I enjoyed it and really appreciate the support we've had from the Diffusion program thus far, and to know that you continue to be on our team is very exciting. Thank you.
Diffusion of Excellence has just been incredible in terms of it's helping us to make this happen. We had it going initially, but it really just snowballed in a positive way once Diffusion got involved. So we're extremely grateful for all the support.
Our second practice came out of the Boston VA healthcare system and has roots in the VA National Opioid Overdose Education and the Naloxone program. To address the high incidence of opioid overdoses, Opioid OD Reversal educates staffs, patients, and other VA healthcare community members on the proper administration of intranasal naloxone, an opioid reversal agent, and distributes it to VA police and places them within automated external defibrillator cabinets. I'll turn over the podcast to Molly Brick, a member of the VA Innovation Support Team, who will speak with Pam Bellino, the Patient Safety Manager at VA Boston and a key player behind the Opioid OD Reversal and a veteran of the U.S. Coast Guard. They're joined by Dr. Elizabeth Oliva and Dr. Jennifer Burden, who are both involved with the VA OEND program. Dr. Oliva is the program coordinator for the VA OEND program, and Dr. Burden serves as the Deputy Director of the Mental Health Residential Rehabilitation Treatment Programs in the Office of Mental Health and Suicide Prevention.
So to start things off, could you all introduce yourselves, including your name and roles at VA?
My name is Pam Bellino, and I'm the Patient Safety Manager here at VA Boston Healthcare System.
Hi, and this is Elizabeth Oliva. I am the VA National Opioid Overdose Education and Naloxone Distribution OEND Coordinator.
Hi, my name is Jennifer Burden. I'm the Deputy Director for the Mental Health Residential Rehabilitation Treatment Programs within the Office of Mental Health and Suicide Prevention in VA.
So Pam, for someone who might be unfamiliar with your work at VA Boston Healthcare System, could you give us a 1-minute elevator pitch?
So the goal of the program is to save lives in cases of opioid overdose by putting the life-saving medication intranasal naloxone, also known as nasal Narcan, into the hands of first responders. So our practice is made up of a 3-layered safety net. And the first layer is the Opioid Overdose Education and Naloxone Distribution Program, also known as the OEND program. And this program was really already established and implemented throughout VA. So my involvement was in the next 2 layers of the safety net, which expanded the availability of nasal naloxone to first responders. And this was done first by, we equipped our VA police with nasal naloxone, and we trained them on how to use it. And the third layer, which really is the most innovative, is that we added nasal naloxone kits to our automated external defibrillator cabinets, also known as AEDs. And we believe that this practice is the first of its kind throughout the country.
So Pam, how did you and your team come up with this idea? What problem were you aiming to solve?
The problem is that naloxone is not readily available in many hospital settings where someone might experience an opioid overdose. So like in cafeterias or on hospital grounds, even our substance abuse treatment programs and our outpatient clinics, we don't have our crash cards or code cards available there. Prior to the start of the program, we actually experienced situations where first responders would come to the scene, recognize that a victim was experiencing an opioid overdose. However, they needed to wait until either the medical team arrived or ambulance before naloxone could be given. And this could result in a 5-minute delay or more just waiting for help to arrive. At VA Boston, to address the problem, we wanted to expand that safety net, so we equipped the VA police with 2 doses of nasal naloxone, and we trained them how to administer the naloxone in cases of opioid overdose.
Did you encounter any challenges in getting this initiative off the ground?
So for the VA police, the major concerns that kept coming up was liability issues and union issues. So on a local level, our VA police chief had to negotiate with our union partners in order to first get the police to be equipped with the nasal naloxone. And then once we had the go-ahead, we needed to then find a carry case that would fit the naloxone on the police utility belts. We needed to get a policy. We needed to get the police trained.
In addition, earlier we heard Pam talk about the work at the local level with the unions to support their implementation efforts, particularly with the VA police use of naloxone. Since that time, we've been able to establish national memorandums of understanding, or MOUs, with the National Association of Government Employees and the American Federation of Government Employees, or AFGE, that support the implementation of intranasal naloxone use for opioid overdoses by VA police officers.
And Pam, can you share any stories with us about veterans who have been positively impacted by opioid overdose reversal practice at Boston?
So in the 3 tiers of the program, in our OEND program, we've had 109 opioid overdose reversals reported by veterans through our OEND program. The VA police have participated in 11 opioid overdose reversals, and the Miami VA has had 1 opioid overdose reversal as well. And we've had 2 rescues using the naloxone by staff who obtained the naloxone from the AED cabinet.
Wow, that's really remarkable. Pam, you stated that your work focused on equipping VA police and AED cabinets with intranasal naloxone. Can you tell us about the plan for spreading throughout VA?
As a gold status fellow, I teamed up with Steve Elliott, the chief of police at the Miami VA. He was the implementing fellow for VISN 8. And the VA diffusion program also supported us with consultants from Atlas Research, and they coordinated weekly meetings and tracked actions to keep the project moving forward and assist with any barriers. So to date, VISN 8 has implemented the VA police portion of the program, and they're conducting a risk assessment to get the AED cabinet with naloxone program deployed.
So, Elizabeth and Jennifer, can one of you tell us a little bit about naloxone for those who aren't necessarily familiar with it and how it effectively reverses overdoses?
Yes. So naloxone is a medication that's been around for decades, and it was originally used primarily by emergency medical staff. And so what's nice and innovative is that it's now available to laypersons to use, which makes it rapidly available and can really ensure that this life-saving medication is in the hands of people who might be close to individuals who are overdosing. So in terms of how naloxone works, it essentially is an amazing medication because it's inert unless opioids are present. So that means that it won't have any effect unless there are opioids in the system. So if a person is administered naloxone and the person is having an overdose, what naloxone does is an opioid antagonist, which means it pushes opioids off of the receptors. That is what kind of lets people start breathing again.
Elizabeth, you spoke a little bit about the safety of naloxone, but can you tell us if there are any concerns or risks of using naloxone?
There are very rare life-threatening injuries post-naloxone administration, well, those are more likely to be related to, excessive opioid dose, co-consumed drugs, or other pre-existing conditions, so not to naloxone itself.
How easy is it to administer intranasal naloxone?
Oh, wow. The new FDA-approved layperson formulations for both types of formulations, the auto-injector as well as the nasal spray, over 90% of people with no training can use these devices. So it's very easy to use.
Can you tell us a little bit about what the VA OEND program does, when and how it originated, and what its goal is?
The OEND program, the very first program, started in Cleveland, Ohio. And if you're aware of the hotspots regarding overdose, Ohio is definitely one of them. And what happened was there was this amazing psychiatrist, Dr. Eric Konecki from the Cleveland VA, who was overseeing a residential rehabilitation treatment program. What's fascinating is that he was able to implement in August of 2013, and we had a national program up and running in May of 2014. And if anyone knows in terms of implementation, to go from basically a pilot to full-fledged national implementation in that short of period of time is really remarkable. And it's really a testament to program offices working together across VA to support this life-saving intervention.
Can you speak a little bit about what else VA and or the VA OEND program is working on to combat veteran addiction and overdoses?
As Elizabeth mentioned earlier, I think this is just one part of a broader piece of VA's efforts to address the opioid crisis. The implementation of opioid overdose education and naloxone distribution, in parallel with expansion of access to life-saving medications like buprenorphine, are going to be critical to our ongoing efforts.
Attention all VHA employees. Do you have a practice that improves veteran care at your facility? Do you want the opportunity to impact veterans and employees nationwide? If so, apply to the 2018 VHA Shark Tank competition. To be eligible, applicants must have successfully implemented their practice in at least one VHA facility, and the practice must address one of the VHA Shark Tank priorities. Compete by submitting your promising practice now. For more information on the VHA Shark Tank competition and the application process, please visit the Diffusion of Excellence VA Pulse page. Our last segment focuses on Project Lazarus, a nonprofit that empowers communities and individuals to prevent overdoses and opiate poisonings, establishing effective addiction treatment and support, and meet the needs of those living with pain. Listen on for the Diffusion of Excellence Assistant to the Director, Blake Henderson's interview with President and CEO of Project Lazarus, Fred Wells Brayson II, and Lazarus Peer Guide and U.S. Marine Corps veteran, Daryl Stone, to learn more about how Project Lazarus has dramatically decreased overdoses mortality rates in several communities.
Daryl and Fred, would you all mind introducing yourself and telling us your name and role at Project Lazarus?
Sure. I'm Fred Wells Brayson II, and I'm the president and CEO, founder of Project Lazarus, based here in North Carolina.
And I'm Daryl Stone. I am a North Carolina certified peer support specialist for Project Lazarus and work with Lazarus Recovery Services.
Fred, let me ask you, would you mind giving us a short elevator pitch on Project Lazarus and its range of services?
Sure. Project Lazarus developed to address the opioid issue in our own Wilkes County, North Carolina, with a public health approach. And we do that by presenting, responsible pain management, preventing overdoses in all age groups and sectors, but also helping those with substance use disorder and addiction through Lazarus Recovery Services, and other sideline projects like, Project Pill Drop, helping people dispose of medications appropriately. Our tagline has always been, take correctly, store securely, dispose properly, and never share, to kind of work against the diversion issue and have people more appropriately take and handle their medications.
Sounds great. Can you talk briefly also about just the general problem you're trying to confront? I know it's probably well documented, and now it's very much in the public conscience, but I just wanted to see if you could maybe talk about it in your words.
When I first found the issue, when I was the interim project director and chaplain for our local hospice, we're going back 13 years ago before anybody else was talking about the problem. And then we realized the extent of our problem here with the sharing and the stealing and the selling of medications, primarily prescription medications, both on the pain side, pain relievers, and benzodiazepines on the mental health behavioral side. And as our community, we decided to come together to address the issue because in 2007, we were the third worst county in the United States for prescription medication overdoses, which to us was a healthcare crisis. We as a community mobilized and worked on action plans for every sector to address those issues, and were able to decrease the mortality rate and emergency department rate and find ways for more people to get into treatment. And the sad part was when we learned that, that wasn't our high water mark. We didn't hit our high water mark until 2009. But that's just kind of points out how much effort and diligence it takes to address this issue.
Daryl, can you talk a little bit about what you were doing before you took on your current role with Project Lazarus, and how did your path bring you to the project?
I've always been self-employed. I was in the Marine Corps. Had not had much experience in the community as far as the recovery community from substance use disorders or substance abuse. But I ended up getting some experience in that substance abuse with alcohol. And I ended up in a 12-step program and 8 years in recovery, and just met some folks in that community. And one of those folks pointed me to the job here, working with clients at the local methadone Suboxone clinic, working with people in the recovery community. And that's sort of what led me to this job and position.
Would each of you mind talking about your specific roles at Project Lazarus? And can you walk us through a day at work for each of you, if you don't mind?
So I do a lot of teaching and training and technical assistance, as well as helping individuals on that individual basis, whether they're currently using in treatment or seeking treatment, and helping them, through their recovery aspects by building community support, helping the community understand the science of addiction so that it's no longer stigmatized, and then they can see it as a disease that needs help and support for individuals, and helping communities, embrace that, as well as build the prevention and intervention and treatment modalities, that are necessary. And then we started the Lazarus Recovery Services to meet some of our own needs here in our community, because we found that a lot of individuals in the small rural community, they really can't change lives much because it's the same family, friends, and environment. So we had to build a greater support network for those, looking for treatment or in treatment and recovery, which is why we reached out to those in recovery to help them get certified, like such as Daryl.
Just working with the clients and giving them my experience and what I've seen others do, giving them options, just being there as support for the client, talking with them, just being in a supportive role, and sharing my lived experience, and just working with the individuals or the groups if there's a group meeting. So just being there for that individual in finding their own path to recovery.
Fred, could you please elaborate on Project Lazarus's work on Operation Opioid Safe at Fort Bragg, Womack Army Medical Center, and with Vision 6 veterans in VA in Virginia and North Carolina?
Back in 2007 and 8, when we were first initiating some aspects of our chronic pain initiative and working with practitioners providing chronic pain and acute pain care, and the introduction of co-prescribing and bringing naloxone, the rescue medication for an overdose, into that mix, and having worked with the North Carolina Medical Board, the medical major down at Fort Bragg at that time at Womack Army Medical Center saw our newsletter in the North Carolina Medical Board forum, and I was also called upon to sort of intervene in soldiers that had developed substance use issues at Fort Bragg, to help them change what needed to be changed in order for them not to be dishonorably discharged and losing their veteran benefits. And we weren't successful with everybody, but we were successful with some. They were able to make that transition, change their lives, get into recovery, not lose their status, and are working veterans today.
Daryl, can you describe the Lazarus Recovery Services?
Lazarus Recovery Services is working directly with clients, working with as a supportive role. It's someone to share the lived experiences, my life experiences. My brother was one of the statistics spoken of in 2007 at 38 years old, lost his life to an accidental overdose of opioids. And working with clients, in finding their path to recovery, being supportive with them. My lived experience they can relate to and identify with. And, in prior military, sometimes, if I work with a veteran, there's a brotherhood or a bond and sort of a friendship right off the bat.
Fred, can you tell us a little bit more about Project Pill Drop?
So Project Pill Drop works with the DEA and their National Take Back Days. So we developed take-back programs within the community where people can bring their old meds and get rid of it with no questions asked. And we would have some patients and families come in with medications that might be 30 years old. They just didn't know what to do with it. They just kept it in their cupboard. And unfortunately, we have people now looking for that medication that's sitting in the cupboard. And then we were able to establish permanent drop boxes or kiosks, if you want to call them, into local law enforcement so that whenever law enforcement is open, people can drop off those old meds there. And then now with the DEA allowance from a few years ago, pharmacies can now take back controlled substances and have those same drop boxes and kiosks, as well as hospital and clinics that have pharmacies.
Could you all speak briefly about any challenges that Project Lazarus has encountered over the years?
So the stigma of addiction is one of the main obstacles. Initially, bringing awareness to the problem was an obstacle, but that is no longer the case because it's normally on every headline in every newspaper around the country. And then helping community sectors bring about change, health systems bringing about change, those all have taken a slower process, though they are, rapidly moving now, but over the past 10 years took a little bit more in order to accomplish that. And then, of course, communities having the resources and materials to be able to formulate and mobilize initiatives. Not every community has the funding. Not every community has the personnel. So that has been slow in the process.
Fred, can you provide any data on the impact of Project Lazarus to date on overdose mortality rates?
But University of North Carolina, through their Injury Prevention Research Center, had evaluated our statewide program, and they found that when they had coalitions who embraced the Project Lazarus model and were developed and embedded within that community with the local health department engaged, they had a 26% lower mortality rate. And they've also shown that when we did prescriber education, within 30 to 60 days, there was a 9% drop. When we did emergency department policy changes, there was an immediate 30-day drop of 3%, and then the rest kind of built from there. Overall, the engagement has, dropped mortality.
I wanted to ask if you have any personal anecdotes of individuals affected by opioid addiction who have benefited from Project Lazarus.
The stories are the community makes the difference. And when they become supportive for an individual's need, whatever that may be, the community rises up, and that's what brings about change.
Thanks for listening to the second episode of the new VHA Innovation Ecosystem podcast series. We hope you learned something about VA and the work employees are doing to improve care for veterans. Join us next time. On our next episode, we'll focus on the use of 3D printing to enhance the veteran experience. Until then, this is the VHA Innovation Ecosystem podcast series.